Good morning. Hello, my friends. This is Jonathan Munoz here again for another episode. And today I just want to tell you more about my day as a hospitalist so you kind of grasp an idea and use it during your conversations, during interviews. You know, what do you think is going to happen in our day? You get to know more about the hospitalist days. Okay, so as I said, I work as a hospitalist, which is usually a branch of medicine reserved for internal medicine doctors, but family practice doctors can work as hospitalists too. It started many years ago, initially in rural areas where hospitals try to have a person taking care of the inpatient population, and sometimes they couldn't get all their hospitalist doctors to be internal medicine, so they started sourcing to family practice. And with time, they realized, okay, family practice doctors have a good fair amount of inpatient medicine experience, so they can do it. And so it has been expanded to family practice as well. And I'm a family practice doc, and I do hospitalist work only. I don't do outpatient. And so I want to tell you today, I came a little early. It is 7 a.m. and I don't have many patients. I have only 8 patients. I started the weekend with about 17, 18, and I've been discharging, sending patients to a nursing home, sending patients home, a couple of them on hospice. So I came to a very limited list today, and I hope to go home early too. So let's start by saying what I do when I get here. So after logging in, get my coffee, get my stuff ready. I print my list of patients for the day, like seriously, a piece of paper everywhere. I don't know of any program using iPads or anything on computers, but as more people that I get to know around, all of them use a piece of paper to print their list and go around. A list of your patients. So on my list, I have 8 patients, and I'm going to tell you what I have with each patient's plan. So I have a lady in observation med surg, and she's young, 33, and she's here for appendicitis. So her plan is probably to continue MPO, get the surgery done today, and hopefully the surgery is uneventful. Hopefully there's no perforation, there's no extreme pain after surgery, and she could go home earlier tonight. So she is a possible discharge for tonight. I'm just gonna write down here. Follow up on post-surgery outcome. Follow up on operative report, because that's what tells me, what happened during surgery. Is there any perforation? Follow up on surgeon's recommendation too, because if the surgeon thinks, this appendix was necrotic, keep him here for 3 more days, then the next step is to convert this patient who is outpatient to inpatient. The reason why is because observation status is only meant to last 2 days. Okay, next one is a patient on a med-surg unit, inpatient med-surg unit, who was a downgrade from telemetry unit, where he was first for acute GA bleeding with a hemoglobin of 4, and we were thinking active GA bleeding, had an endoscopy. The endoscopy found an open ulcer in the duodenum with a visible bleeding artery. So those are, if you can read about that, those kind of bleedings have a special treatment besides IV infusion PPI for 72 hours. They also have some special monitoring. So this patient, post EGD, stopped having melanotic stools. The following hemoglobin checks were stable, and now I just want to keep him 1 more day to see if he remains stable, he's symptomatic. So today is his possible discharge day. See how he has transitioned from telemetry, where he was unstable and required constant monitoring, to med-surg now, where his hemoglobin has been shown to be stable, his vitals are stable, and he's about to be discharged. So that is kind of the process. Telemetry, med-surg, you always have to downgrade in the hospital as much as you can. Think about every day as a hospitalist, your work, or as an internal medicine resident or family practice resident on the inpatient care setting. your job is to think, how am I gonna get this patient discharged home the next day? What is getting me closer to discharge this patient? So for this patient, it seems like his hemoglobin today is 9 and has remained on that level 8, 8.5, 9. So he's ready to discharge. Okay, another discharge. So 1DC, on this one I just gonna write down that I need to follow up. Basically, I just do a little square and then follow up, which it looks like FU, but follow up on hemoglobin, then follow up on symptoms, and FU gastroenterologist recommendations, or follow up gastroenterology recommendations, not the other FU. Okay, and the next one is another patient in a med-surg unit who is here. This is another downgrade, and his downgrade history comes from ICU. This guy is 90 years old and had a perforated diverticulitis with septic shock. So admitted to ICU, vasopressors, antibiotics, intubation, slowly improving, had surgery, and has a colostomy bag now, is slowly off vasopressors, slowly to the point of extubation, and then once he was off of all this, he was transferred to telemetry. And on telemetry, he remained stable, he remained on an NG tube though, he remained stable, febrile, tolerating wound care, and recovering bowel function. The only thing that we found in telemetry is that he had a positive blood culture for E. fecalis. Now, with the infectious disease recommendations, we started him on antibiotics and waited for culture results. The culture results said, well, he will do fine with ceftriaxone and ampicillin, so we put him on that, and his repeat set of blood cultures 3 days later was still positive. So at this point, because of how long has he been bacteremic, we decided to do a TEE. Now, a TEE is preferably done in the telemetry unit. Why? Because with all the anesthesia, all the stimulation, an old patient that is at baseline in a poor functional status can get a little worse. So thinking of that, he remained on telemetry and now it's much better. The TEE did show vegetation, so he has now another diagnosis, which is infective endocarditis. And now that he's very stable, had all his procedures, is tolerating diet by mouth. We removed the NG tube and started him on a diet. His wound is looking good. We are transferring him to med-surg. He's on med-surg now, waiting for his blood cultures to clear. Once his blood cultures are clear, that's the date that we set the initiation of antibiotics to complete the course. So for him, it's going to be 6 weeks. He is on med-surg. So I'm going to follow up on blood cultures. I'm going to follow up on wound care. And how's he doing, basically? His blood work looks fine today, nothing to replace. There's a little potassium low, like at 3.2. So he's taking PO. I'm going to give him 40 milliequivalents of PO potassium liquid. And that's it for him. So he's waiting for his blood cultures to turn negative, and then we put a PICC line. And after the PICC line, he could go home. See, I already have a whole plan in my mind. Okay, next one is a patient that is young. She had a fall. She's on a med-surg unit. She had a fall yesterday, mechanical fall, and she fractured her ankle. Initially came with a dislocation. It was reduced in the ER, and then orthopedic surgery said, well, we're going to fixate it, and they took her to the OR yesterday. And her plan, basically, since she's young and had otherwise simple surgery, we're going to keep an eye through the morning, on her lesion and see if she's comfortable with the pain, she tolerates the pain, the medications work for her. Since this is a closed injury, there's not going to be any need for antibiotics. So basically, as long as she's able to tolerate pain management, then she should be able to go home today. So I'm just going to follow up with ortho surgeon recommendations and possible discharge. Next one, okay, now you're moving to telemetry unit. This lady, 88 years old, and she came with severe hyponatremia. She was having diarrhea for 2 days, nausea and vomiting, and on top of that, she was eating poorly, and she was still taking her hydrochlorothiazide for hypertension. So a combination of things. Probably when she came, she had a CT scan that showed possible enteritis, and her sodium was 108, very low. I was I was expecting a little seizure somewhere there, but it didn't happen. It, but it does raise concern, right? So a patient with a sodium level acutely reduced that low with symptoms of nausea, vomiting, dizziness, you are thinking the worst, so we sent her to the ICU. In ICU, she was on 3%. They slowly improved the sodium to 110, and now much better. So after this, she was transferred to MedSurg, and in MedSurg, she's doing. Oh no, she's still in telemetry. She was still in telemetry, and doing fine. The sodium is 132. She's not vomiting. We believe she had a little colitis, but nothing like C. diff or giardia. So she is good to be discharged today. Um, the only difference is that her PT evaluation showed that she was only able to get up from bed with assistance. She needed assistance and she wasn't able to walk, which is below her baseline. Uh, Normally, she is able to walk with a cane at home without any restrictions or without need for assistance. So see how there is a loss of function. So for this, we have requested for her to go to a skilled nursing facility to continue inpatient rehabilitation. So she will go today to a skilled nursing facility. Next one, it's another telemetry patient that is a COVID-19 lady. She's 90 years old and she had COVID. So for her, we gave her the whole thing. We gave her a couple of antivirals and dexamethasone. She's much better. She's eating. She is on 2 liters. What I'm gonna do today is I'm gonna get her insurance to give me authorization to give her a portable oxygen unit and a concentrator oxygen unit for her to have continuous oxygen at home. Usually these patients that are recovering from COVID, like her, that she initially came with a need for 15 liters and slowly taper down to 2 liters, she will come out of the oxygen, but it will take, I don't know, a month. And but other than that, she's fine. She has a room to isolate at home. She has. I'm gonna get her the oxygen, and after I get all that, I can discharge her. The next one is one of my patients I see at the nursing home that was brought to telemetry because she was very short of breath and her oxygen saturation was on the 70s. So we did a CT scan. We found that she had pneumonia bilaterally, like real consolidations. And so we started on antibiotics, and slowly from 6 liters that she was using, now she is on 2 liters. And I think I can get her out to the nursing home today because she seems much more improved. And the next one is another telemetry patient that came. He's old, he's 85, and he came from home for confusion, for a very inexpressive face. So here we did a CT scan of the head. Well, first his INH score was very high, like 20, and then we did a CT scan of the head, and it showed cerebellar stroke. And her symptoms got worse. We repeat the CT scan. There was some progression of the amount of infarction area. The neurologist didn't recommend much about this other than continue physical therapy and see if he would be able to eat. He wasn't able to eat on time and failed to swallow evals. and was aspirating, so we recommended for him to have an alternative way of nutrition. So he got a G tube. Now he's bedbound now, and this is a very big loss of function. He was able to walk before, he was able to talk, he was very high functioning before, but now he's bedbound. He requires a G tube, and his recovery prognosis is very poor, to say something. So his family has requested for him to go home on hospice. So all that we did so far, it's appropriate, and even on hospice you can go hospice after getting a G tube, because for some families it's okay to not to feed a patient and wait for the death process to continue, or some families they say, well, we want him to be able to receive feedings. It's important for us to know that he's getting some nutrition, and but we're not going to stop the his process, the process that's killing him. So once you evaluate all the requirements for a patient to qualify for hospice, and the family has consented for it, then you can call a hospice agency that connects to the patient, gets the paperwork done, all the clearances, and prepares the house for a patient to arrive with what we will need, like a bed, oxygen supplies, medication for anxiety, for pain, the nutrition supplements. Once all of that is arranged by the hospice company, you can discharge the patient. So this patient is going home today too. And that is the beginning of my day in the hospital. Hopefully gives you some ideas of what you get into when you start doing observerships or virtual rotations, and is useful for you.